these cells can be destructive and invade other tissues. Cancer isn't just one disease, but many, and it accounts for nearly 1 in 4 deaths in the US every year. It touches everyone. Not all cancers are inherited, but all cancers are genetic. That leads me to the topic of my presentation: the determinants and outcomes of genetic testing in cancer treatment. Our study encompasses lung, colon, and breast cancer, but I will be focusing on lung and colon cancer. To roadmap my presentation, I will first be going over the significance and overall aims of our project. I'll then give you some background on the cancer in Pennsylvania compared to cancer in the United States, and also outline the different somatic mutation tests that we've been looking at. I'll then give you an overview of my projects and go through them individually, giving you the aims, methods, findings, and my role in each one. I'll then talk about policy implications and lessons learned. So nearly 600,000 deaths in the US are projected in 2013. 13% of these are in Pennsylvania. Looking at this map of the frequency of lung, colon, and breast cancer by county in Pennsylvania, we can see that Philadelphia falls into the most dense category, with lung cancer accounting for 10,000 cases and colon cancer accounting for 5,400 cases between the years of 2004 to 2011. There are over 100 different types of cancer, but these three account for 61% of all deaths from cancer in 2013. Using CDC data from 1999 to 2009, I plotted the incidence and mortality rates of Pennsylvania and the United States. Here, we can see that the rates of Pennsylvania are not only similar to those of the United States, but are higher than those of the United States. However, we can see a pattern within the past decade. Rates are decreasing. The overall aim of our project is to identify the determinants of patients' receipt of mutation testing and their outcomes. So the different drugs used in chemotherapy, direct costs, survival of patients, and disparities in treatment. We are also looking at how somatic mutation testing varies by race and technical challenges, such as different methods of obtaining tissue samples for testing. Our 4 data sources are the Pennsylvania Cancer Registry, Penn Data Store, Independence Blue Cross, and Medicare and Medicaid. We are using PCR to identify the patients with advanced stage cancer, and then PDS, IBC, and Medicare and Medicaid to cross these and validate the claims of the testing. So we looked at 3 separate somatic mutation tests. These are basically used to help determine which drugs are best used for treatment and chemotherapy. We looked at epidermal growth factor receptor mutation testing, KRAS, and Oncotype DX. EGFR mutation testing is used for lung cancer patients, KRAS for lung and colon, and Oncotype DX for breast cancer patients. So the reason why we're looking at these tests: a 2009 study showed that patients who were EGFR mutation positive benefited more from tyrosine kinase inhibitors like erlotinib and gefitinib, which basically inhibit the signaling of EGFR that lead to tumor growth. In contrast, patients who are EGFR mutation negative benefited more from carboplatin and paclitaxel, which is the regimen for standard chemotherapy. In terms of KRAS testing, then a 2008 study showed that patients who tested positive for KRAS did not benefit from cetuximab, which is an EGFR inhibitor. In contrast, we can look at KRAS mutation negative, or people who were wild type for KRAS, and they did benefit from cetuximab in addition to best supportive care available. An overview of my projects. So my first project was a validation of claims data for somatic mutation testing, and the second was a systematic review of the suitability of using cytological specimens for mutation testing in lung cancer patients. So in order to understand the outcomes and costs of mutation testing, we have to look at large databases. And the only large databases available right now are claims data. So how does claims data come about? So first you start with receiving care at the hospital, and then the physician orders the somatic mutation test. This is then documented in electronic medical records such as Epic, which is what Penn uses. And then there's claims data for these mutation tests. But there are a bunch of steps in between, so how accurate are these really? So that's what we're trying to do. Through a validation of claims data for somatic mutation testing, we're using data from Penn Data Store to verify that eligible patients are receiving mutation testing, and that mutation can be identified in both medical and administrative data records. So in this case, we're using PDS in place of claims data, and that's possible because they track the billing codes that UPHS uses for reimbursement. Our targeted population were patients who were 40 years of age or older, diagnosed between 2007 and 2010, and had invasive lung, breast, or colorectal cancer, and were also treated or diagnosed at Penn Med. After we compiled the list of lung and colon cancer patients that we wanted to look at, I created a case report form in REDCap. So this basically outlined the patient's types of cancer, details of their cancer, their treatment, and the mutation testing details. So we looked at when the tests were ordered, what the results were, and when we got the results. We stripped all of these patients of identifiers, and then after importing them, and then I went into Epic and did chart reviews on them. Awesome. So now there are a lot of documents to look through, and we had a lot of questions, but it wasn't that long, thankfully. So the way I found this information was focusing on doctors' notes in office visits. I also went into lab reports to look at PDFs that were scanned in. So a lot of the PDFs included the tests that were ordered, which included EGFR mutation, KRAS, and oncotype, which we haven't really looked at that closely. They also had a lot of results for EML for ALK, which is not something we're focusing on in this study, but we are in the systematic review, which I'll go over later. So what we found, we started with 2,700 patients who were both in PCR and PDS. And then I went into STATA and extracted the patients who were diagnosed in 2010 and also had IDC insurance. The reason why we're looking at patients who are diagnosed in 2010 is because that's when Penn switched to in-house testing. So before, they would send out KRAS tests to labs such as Clarion or Response Genetics, but then they switched to in-house, which makes it hopefully a lot faster. We also looked at IBC insurance because that's the claims data that we received in terms of private insurers. After screening 365 patients, we found 111 who were diagnosed or treated at Penn, and of those, 28 received testing. We did the same with colon cancer patients. So from 574 patients in PCR and PDS, we found that 10 were treated or diagnosed at Penn, and of those, 2 received testing. I heard some gas. The reason about that is there are less colon cancer patients, so keep that in mind. One of our goals for this project was to ultimately create a 2x2 table that can show that claims can be validated from somatic mutation testing. So the numbers I described earlier fill in the totals of this table. If we add those up, then we find that 25% of patients treated or diagnosed at Penn received mutation testing. One of our next steps is to cross this data with claims data to see that they can be validated. And then we can calculate specificity and sensitivity. So sensitivity is basically the probability of a positive test given that a patient is ill. This means that we're looking at true positives over the sum of true positives and false negatives. So once we have this data, then we can look at the sensitivity of lung, which would be P over 28, and then for colon, it would be P over 2. Specificity, on the other hand, is the probability of a negative test given that a patient is well. So this is true negatives over the sum of true negatives and false positives. And that would be N over 83 for lung and N over 8 for colon. So my role in this project, I did some data synthesis and creation of tables and figures that may or may not have been included in the annual report. I then did some literature reviews of overall aims and testing. I had the pleasure of doing the IRB protocol for this sub-project, created the case report form in REDCap, and then validated the claims data for testing in EPIC. Again, as I said, our next steps are to cross the data with the claims data and develop the manuscript. My second project was a systematic review of assessing the suitability of using cytological specimens for somatic mutation testing in lung cancer patients. So when I was talking about our overall aims earlier, one of the things we want to look at is how mutation testing varies by technical challenges. which I said were the methods of obtaining tissue samples. In general, these tests are pretty accurate, and they are good at detecting mutations. We can see here that 54% mutation was found in the tumors that were completely tested. So our inclusion criteria for this systematic review was looking at articles that had original data on the sufficiency of cytological samples and the sensitivity of mutation testing. Going into Embase and PubMed, I found 134 unique articles, and of those, 19 had sufficient data and relevant data that we could then use for synthesis and analysis. So we can see here that the overall sufficiency of cytological specimens is quite high. The minimum here is 72.2%, and the maximum is 100% in 3 studies. Graphically, the bubbles here are proportionate to sample size. So we can see that the smaller sample size are near the 2 extremes. So they're really close to the 100% and also close to the minimum of 72%. One of the more frequently used methods of obtaining cytological samples that is less invasive than surgery is endobronchial ultrasound-guided transbronchial aspiration, otherwise known as EBUS-TBNA, which you may argue is a lot easier to say. What this involves is putting a special bronchoscope down your mouth and through your trachea. The physician then uses an ultrasound to look at the structures right outside of the air pathways, or bronchioles and bronchi. And then a needle is inserted into the lymph nodes to extract this tissue and then use the cells for often, yes?
Does the needle go through the
Okay. So basically, this, the green thing is the lymph node, and then that's the needle. So the way it works is when it's put down your throat and through the trachea, then that's closed. And then once it's inside and they're looking around with the ultrasound, then it opens and the needle comes out and goes into the lymph node. Yeah. So that extracts extracts cells, and usually that's used for staging lung cancer. We can look at these cells here just to see what they look like, and then you can also see the needle that's going into the lymph node. So the sufficiency of using EBUS-TBNA to extract these cells. This again is also pretty high, which is good because it's less invasive in terms of extracting these cells. The minimum here is 72.2%, and the maximum again is 100%. That's another graph of it. We can see here that more recently than the number of procedures or the sample size have been increasing. So that may imply that people have been using this more frequently. We can also look at EGFR mutation testing specifically, and the sensitivity of EGFR detection using these cytological specimens is also quite high. The minimum here is 63%, and the maximum again is 100%. Graphically, we can look at it like this. My role in the systematic review was to do searches for and collection of relevant articles, did a review of the studies, extracted data, and produced tables and figures. Our next steps are to synthesize the data and analyze it. We are also going to further develop the tables and figures and develop the manuscript. Policy implications. So we would think that somebody who receives a mutation test and receives the right treatment down the line will induce less cost than somebody who does not receive mutation testing and then has to get a lot of insufficient chemotherapy drugs and other treatment that does not help with their cancer. So hopefully we can improve treatment and survival in cancer patients, and also improve the quality of documentation of mutation testing and see that these can be validated with claims. Other implications. So one of our goals was to look at how mutation testing varies by race. If we can show that racial disparities in costs are decreased, then we'll be able to influence the policies that impact what the costs or the funds that go into these genomic technologies are. So hopefully we can increase the policies to improve access of genomic technologies to minority populations. This summer, I was able to complete an IRB protocol, created a case report form in REDCap, analyzed lab results and EPIC medical records. I also discovered that obtaining data is a waiting game, and it's an uphill battle. I think we've been waiting for IBC data for a year now. Also conducted a systematic review and was able to hone my Excel and Stata skills while synthesizing data. Special thanks.
Remind of medical school, the time on Epic will not be misused.
That's my mentor, everyone.
The more you learn in Epic, the better off your life will be.
I actually like Epic now. So special thanks to my mentors, Joanne, the summer staff in LDI, and the rest of our GCAP team. These are my references. Thank you. I'm happy to take questions.